Hello.
Hi, everyone.
Welcome, welcome. I just put a message out. Welcome from, or hello from hot and muggy Florida. It is hot.
I can say the same about here in the middle of Missouri. It's outside my door. It's very hot and muggy.
So Barbara's saying hello from Alabama. I have a feeling it's hot there too.
Yeah.
And Faith from Oregon.
I bet it's not hot and muggy there, though.
We have Omaha, Nebraska, Minneapolis, Miami. We have you guys so well trained.
Yeah, we really enjoy that. Thanks for telling us where you're from. Central Texas. Woohoo!
Tejas. Very good. Well, we have a really good show for you tonight. We got 3 topics we're hoping to get through and some good commercial break slides that we've been working on. We got a new thing to share with you that we're counting on you to help spread the word to people that we think it could help. So look forward to that. I think, let's see, I'm just going to go through the next slide because we're 1 minute in. Some people are still, people are rolling in here.
Yeah.
Give them just a second. So how was your week, Alicia?
You know, it was really busy, but I've been so distracted with family and everything the past month or so, actually more, the last couple of months. And things are slowing down, and it feels good to be back in the trenches. And can we knock on wood if it's going to all get back to normal or what we used to think was normal? So
yeah,
it's fun.
I have, being in Florida, it's very hard for me to get used to this because I was in New Jersey, as a lot of you probably remember, and my kids went back to school on Monday, the 11th, August 11th. And it's so foreign to me to have them start in the middle of August, even though we've been here since, 2018. It's just, it always comes as a shock that they're supposed to be going back to school already, because I'm so used to it being, like after that, what is it, Labor Day?
Yeah, yeah.
And so at any rate, so they're back in school, and I got my youngest is 16. I can't believe it. So 2 more years and they're all going to be flying the coop.
My number 3 turned 26 this week, and I kept telling her, "No, I'm pretty sure you're 24." And she said, "No, I'm 26." And I'd say, "No, I'm pretty sure you're 24."
Oh goodness.
Oh.
All right, well, let's get started. I'm going to run the slide deck, and Alicia and I will be doing our own individual answer sheets. I got 1, she's got 2. Carrying the load, she is. So we're going to be covering endovascular cases. We started that last month. We got through a couple of the endovascular. So we're going to finish that up. And the E&M one that we didn't get to the last webinar, we got that in here. So I think you'll enjoy this. Pretty meaty stuff.
Mm-hmm.
This is a slide where we like to encourage everyone to become a club member. And as a club member, you get access to the recordings, which we call replays. You get the slides, you get all the answer sheets that the interns and us tweaking what the interns did. You get all that valuable stuff, and CEUs, of course, in the club. We do these live broadcasts so everybody can listen and learn for free. But if you want the CEUs and all of the goodies, then we do need your support by you becoming a club member. And we have 2 ways that you can do it, or actually 3. You can become a monthly club member, which is only $24.99. And this is where you get the always open access. You get, we're actually going to be changing this. So if you are already a monthly club member, we encourage you to not let that lapse, because we're making changes. The Batcave access and access to previously purchased courses that have expired are no longer going to be a bonus or a benefit for monthly club members. That is going to be reserved for the annual club members. And I'll be honest, I'll be completely transparent. We have some people, unfortunately, that come on and go off. And administratively, we have to add them back to all the previously purchased courses. And it ends up costing more money to manage that than we're actually making. And we need the money to support the development stuff. So we're going to make those bonuses or benefits for annual club members. So keep that in mind. If you're a monthly club member, hang on to that. You'll be grandfathered in. But if you let it lapse, the only way to get it back is to become an annual club member. And annual club membership is $249. So basically, you're getting 2 months for free, or you save $50 a year, whichever way you look at it. The CCO Club Plus, that's when you want to do a course and the club, and you pay $329 to get in, but then it's only $99 a month, and you can take all the courses if you want. And you get to take, we are making a new change. It used to be one course at a time. Now we're going to let you do 2 courses at a time. So if you want to do medical terminology and physician-based coding, you can do that. And then when you finish one and you want to take another, you just let the help desk know through the Academy app, and they'll get you set up for that. And any course that you complete while you're a Club Plus member, even if you downgrade to the annual, you'll get continued access for as long as you stay an annual club member. But we have one more slide. We have a sale. We mentioned this last webinar where it's instead of $249 for the annual, it's $199. And we did this in honor of the new launch of our CCO Academy app. So if you want to get in on that, $199 for a whole year. So now you're in essence saving $100 a year over doing the monthly. So this is the link. When Alicia starts to do her presentation, I'll put this link in the chat so you can go direct to it, but it's right in the app.
And you were just saying that you've had several people take advantage of that sale. So
yes,
and they're enjoying it.
Yeah, I got a good interest after the last webinar. So, okay, so Alicia's up first. And if you want to pull up your answer sheet and share that. Do you have it pulled up?
I have it pulled up. Oh, there's the button. I almost hit the going out the door button.
No, don't.
I hovered and I was like, wait, stop. Okay, hold on. Let me just pick which screen to show you here. Let's see. I've got things on 2 separate schemes. Was it 1459 or 1458?
59, the endovascular cranial.
Okay, I'll just share that screen. Okay, got it. Sorry about that, guys.
You're good.
That's what happens when you have 3 monitors going at one time, right? Well, as you guys remember, as we get back to doing these fabulous webinars like we did in the past and giving you an answer sheet where the content flows versus a slide deck, one of the things that we wanted to highlight is that we cover the questions that you send us. And if you're in the club, if you're a member, then of course we'll pick your questions first. You get priority. However, we need to hear from you about the questions that you want unpacked and more information on. That being said, we want to give a shout out to Beverly. Beverly is one of the CCO club members that wanted more information about endovascular cranial coding. Our intern, let's see, Priyanka, she is the one that prepared the slide deck. And then myself and Laureen are the ones that get that information. And again, Beverly had asked, can you just give us anything on endovascular cranial coding? And we did. We found some great stuff. First, it's very important to understand what endovascular cranial procedures are and how they work. If you don't have that foundation, then it's a stumbling block moving forward. I have found now by doing a lot of both clinician auditing and coder audits that if the coders, I can tell when they don't have that foundation under their belt. And unfortunately, that makes them slower. It makes them not hit their benchmarks. And why make that happen? If you're going to be coding in a specific area, if there's something you don't understand, get out there and do research or let us know and we'll help you out. So looking at the endovascular, It typically is minimally invasive procedures most of the time. And what they're doing is ultimately is they're working within the blood vessels themselves. And when you say cranial, then of course it's going to be in the brain. And a lot of times it'll be neurological and vascular conditions. So keep those in two separate boxes. We have a neurological condition that is the brain tissue itself, the brain, or a vascular issue, which is going to be the blood supply to the brain. Two separate categories. Now, how do they actually do these procedures? A lot of times you'll see references to the catheters that are used, which would be the tube or the lumen that they're going to put wires. These are very fine, tiny little micro wires. And a lot of times there'll be imaging guidance. Now, when with this imaging guidance is usually fluoroscopy, and it's real easy to go out and do research. You can see, put in your Google search fluoroscopy images, and it'll show you some. I think we've got some here for you to see what that looks like. But know that you're working with minute little vessels and in an area where you can't make mistakes. That's why they have imaging. And a lot of times in the codes, you'll see with or without fluoroscopy and or imaging guidance, and then sometimes you'll see it two separate codes. So pay very close attention to your code descriptions to see if the fluoroscopy or the imaging guidance is included in that code or not included. That being said, the procedures a lot of times will offer alternative to traditional, opening up the cracking the skull and, getting into minute little vessels. It really is nice too, because even though it's invasive, it's a smaller incision area, and it means faster recovery, fewer complications. Interventional radiology is huge. They're finding that it's more than just working on the heart. We're using it for all areas of the body that have a vascular system, which is everywhere, because they can get in and take care of a bleed or a problem even before the patient goes into surgery. They can do it that fast, which will cause a lot of prevent a lot of problems during the procedure and save time for other procedures, like if there's a massive accident or something. And it doesn't have to be just head trauma, throughout the whole body. Now, the conditions that are being treated, a lot of times you're going to see things not just in the brain, but remember, neurological is the brain, and the spinal cord, and then the nervous system going out. So we have central nervous system is the brain, and the spinal cord. Peripheral is everything else. And we have, just like the vascular system, it's all over our bodies. So neurology isn't just about the brain. However, one of the common things is a brain aneurysm. And it's brilliant that they're able to treat a brain aneurysm this way, because again, it's less invasive. Now, it could be called a cerebral or an intracranial aneurysm. Cerebral is your brain, and it's a part of your brain. Intracranial just means anything inside the cranium, so past the skeletal part. And ultimately, the easiest way to remember an aneurysm is that it's just a little weak spot in the vessel, and it makes a balloon, a little bulge as that tissue wears out. Now, this causes a multitude of problems. One, there's the fear that you're going to rupture. And when you're talking about vessels, whether they're veins or arteries, you could bleed out pretty quickly. And remember, the brain doesn't repair itself. So if you get a buildup of pressure, it is going to damage tissue in the brain, as well as not get the blood supply. And so there's a lot of reasons why that is problematic. And then the potential of rupture is probably the number one thing that we're trying to prevent. But there's other things that aneurysms can cause. Sometimes they're very, very tiny, which again, we're looking at little tiny vessels, but they can cause, the aneurysm itself can cause bulging and pressure. An aneurysm isn't necessarily ever going to be felt or noticed. You don't get signs and symptoms usually with a small aneurysm, but you could. The other thing is that when the blood flow isn't smooth, then the body starts trying to compensate. And if the body or the brain detects that the blood is not running through the system correctly, it might run more platelets, right? If you got a bulge, it may think that there's a hemorrhage there. That's why people with AFib, excuse me, end up getting put on anticoagulants, because of the arrhythmia makes the brain think you're hemorrhaging, and then you get a clot, and as we know, that can happen. That can be quite serious. So the same thing can happen with aneurysm. So if a known aneurysm, no matter where it's at in the body, they're probably going to be put on anticoagulants. And again, it doesn't matter what type of vessel it is if there's a bulge. Now, arteries and veins are different. Arteries have that elasticity, more likely to have a bulge. Veins have valves that keep the blood flowing in one direction. You can still have a bulge in a vein. That's where you get varicose veins, right? They're all bulgy. However, we tend to think aneurysm artery more often because, again, it loses that elasticity and starts to balloon out. Doesn't have to be that way, though. Blood vessels that have malformations or fistulas, these are called AVMs, or arterial venous malformations. This is when you get like this abnormal tangle of blood vessels, and it causes problems where they twist up and knot up. You can imagine how intricate these vessels are throughout the body. This is usually a congenital thing, but not always. If they start becoming malformed, or think of a mass of in your legs, what am I thinking of? I just said it. The veins and everything, varicose veins. But think of a whole bunch of veins being varicose veins in a cluster. That's kind of what's happening. It can be a malformation. You can have a fistula where it closes down on there, and that arterial malformation is going to be most often abbreviated AVM. So that's something to write down in your notebook if you weren't familiar with that term or abbreviation. Let's see. If you have a one in the dura, which is that hard membrane, that it's not hard, but think about the shell, the membrane in an egg. So between the white of the egg and then that membrane and then the shell, that membrane is what we think of as like the dura. It's really quite durable. That can be a dural arterial fistula. If we do have a rupture of an aneurysm or a clot, then that can cause a stroke. And two types, we have ischemic and hemorrhagic. They need to identify which type it is very quickly, because the treatment or the plan of care for each of those is going to be different. So hemorrhagic, you're not going to give a clot busting blood thinner like TPA, because you'll bleed out. But ischemic, where there's a clot, that works really well. And sometimes it can even take away all the signs and symptoms for a short while that's working. And again, just remember that's a clot that can happen. And here's an example, this little area that they've got highlighted where you have a bifurcation, and then you've got a little fat tissue or a piece of atherosclerotic tissue that breaks off and just gets caught in that bifurcation. No blood's getting through, and you're going to see signs and symptoms almost immediately when that happens. You can also have tumors, and the tumors can build up extra blood flow to those tumors. Now, we don't always realize that when we're thinking of cancer. We think, okay, there's a mass. Let's say there's a pea-sized mass in the brain, which could be really problematic, even though it doesn't seem like that would be very big. Another problem is that tumor, to feed the tumor, it develops more blood flow. The vessels grow and start wrapping around like the roots in a tree, and that causes problems. So that supports the tumor growth. So sometimes they go in and they cut that blood supply off, and that in turn would make the tumor not be able to be fed. The common endovascular cranial procedures is divided up in endovascular coiling. Now, they usually use this to do aneurysms. So what they do is they take these platinum coils. So platinum doesn't deteriorate like a copper or other types of wire. That's why people want platinum jewelry. It doesn't wear out. And then they, through the vessels, they run that up in there, and that coil supports the vessel so that it can't balloon or break. It gives it support, and it literally looks like a coil or a spring. Mechanical thrombectomy. Now, this is really cool because when you have an ischemic stroke, like what we were seeing where that clot was at that bifurcation, they will go in and they'll go through a large vessel, and it'll just get smaller and smaller as it bifurcates. They'll put a stent in there. They can retrieve or even bust up that clot and pull it back or aspirate it back into the catheter to remove the blood clot. Pretty easy, right? And so that's pretty amazing. They've been doing that for quite a while. And then there's an embolization procedure. And this is where they're going to go in and stop a blood supply. They treat things like those AVMs that we talked about, or the dural arterial venous fistulas. That, by the way, is abbreviated with a DAVS, if it's plural. The synthetic materials like those coils, sometimes they have particles or even liquid agents that can go in and block that blood flow, kind of like a super glue that hardens real fast. They use that to treat uterine fibroids now. They've been doing that for a long time. And so instead of having a hysterectomy, you can go in and through that vascular system, and they'll put these little pebbles in there that'll kind of blow up like bulba tea, and that'll stop the blood supply. And then the fibroid either, starts to shrink because it's not getting blood, or it doesn't grow anymore. So it's been done for a long time. They can do it in the brain as well. And it's pretty fascinating. They can also do flow diversions. And the way that's done is they put this special agent into the blood flow, and it's away from the aneurysm, and it allows the body to heal the aneurysm over time. Kind of fascinating. I think this is an area that's growing a little bit more, relatively newer. But one area that we've been doing for ages, it seems like, is angioplasties and stenting. And when we started with breaking off interventional radiology as its own department. This is the bulk of what they were doing, angioplasties and stenting. And a lot of times it was done with the heart, and then they would do the brain. Now they do these everywhere in the body. So it's quite a fascinating area to get into. It is an area that needs coders, interventional radiology, as that has grown and become quite an amazing specialty. And for these, if you have atherosclerotic disease or intracranial or ischemic atherosclerotic disease, that's when those arteries inside the brain start getting narrowed. So we're not talking about the outside. Remember, you have vascular system going inside, and they clog up. Now, what are the advantages of doing this type of procedure? The number one is that it's minimally invasive. So it really requires a small incision versus having to do like a craniotomy type thing where they will, make a large incision and either do a burr hole or some way to get into the skull itself, to the brain. And they make this little incision. It can be done at the wrist. It's often done at the groin area. There's shorter recovery time, of course, and there's fewer complications because even though it is a major surgery, it is less invasive, and the healing time is much better. There's other reasons which it would be something that you might want to practice is the pros and cons of having these type of procedures. Write them down in your notebook, and you'll see that they'll talk about that in the op report when they consulted or counseled the patient on these procedures. So now let's get into those codes. Now, it seems intimidating. It had always been intimidating to me in the past, but once you get this under your belt, you're going to realize that this isn't difficult at all. Pay attention to the descriptors in the area. So this is where the bubble and highlight really truly shines. Okay, these areas are going to be bubbled, and you're going to highlight and underline the key terms that will keep you in the right area. So the endovascular cranial procedures are going to be 61623 through 61651. And again, these are endovascular therapy procedures. They're on the skull, but not just the skull. We're doing the meninges and the brain. The meninges is part of that system. The specific codes in the range, and we're going to look for those key terms. Again, endovascular. Now, note, this is 61623 is a temporary, but it's a balloon. So you would want to highlight that. So we'll just make that yellow. And we also know that it is arterial occlusion. Okay. So the arterial is the vessel that is being done, but an occlusion means it's completely blocked. Now that's pertinent to understand that. But then the key is the specificity. This is the head or neck. So the endovascular, but if it's not in the head and neck, it doesn't matter. You're in the wrong place. Then our next code, the next two codes, 61624 and 61626 are transcatheter permanent. Okay. So different than 3. This is a permanent occlusion or embolization for central nervous system. So we're going to underline that when you do your bubble and highlight. Or the next one is non-central nervous system, head or neck. Okay, very key. If we aren't going to, now an occlusion or embolization, occlusion means nothing's getting through. And an embolization is another term for that. So that's what I had done on my fibroid, was an embolization. Then we get into 61630. This is also a balloon, but it's an angioplasty. So they're looking at atherosclerotic stenosis, right? So this is a angioplasty. So we're going to make that yellow. And then the other code, 61635, is the stent placement, right? But notice we're not done. With or without an angioplasty. Okay, that separates those. 61645, intracranial percutaneous arterial transluminal mechanical. That all sounds intimidating, but here, it's a thrombectomy. They're going to go out and they're going to go get the thrombus or the clot. That includes diagnostic. Very important to remember, diagnostic is a key term. That means they don't necessarily know what the problem is. It's still an angiography, and they do catheter placement. Now, considerations. When you go to code these, you have to think to yourself, is they're bundling. So right here, we see that with or without angioplasty. So if they go in and they do this intracranial angioplasty, then you're going to use the 61630. But if they put a stent in, then you're going to also use 61635. Can they put a stent in without the angioplasty? Yes, that would be the 61635 by itself. So that's where you get into the bundling. Be very careful. Vascular territories are important. We've talked about those in the past, and you're going to see those on YouTube. And then also look at the documentation where I've highlighted and underlined these words. When we talk about endovascular cranial procedures, this is our key. These are the key terms you want to look at when you do your bubble and highlighting. And I think that wraps us up, Laureen. Can you grab it, or do I need to stop sharing?
I think, let me try this. I think this should work if I just go like that. Oh, no, maybe not.
I'm going to stop sharing.
There we go.
There we go.
Okay, so before I jump into my E&M topic, we had this slide presented for you. This came from a student. I'm not going to share her name yet because I don't know if she's okay with that. But I was doing a coaching call with her, and she had let me know that she had signed up for, I don't want to say their name, but a large company that does coding courses and certification, and that it was just horrible. And she did not consider herself someone who would like struggle that way. So she found out about CCO, was kind of vetting us. And when we had the special for the launch, July 4th, she took advantage of it. We had 50% off, and she loves it. And she was just raving about it. And it got me to thinking, because, Alicia and I have been doing this for a long time, like a long time. And we always hear that, oh, I wish I found you first. Wish I found you first. But at least we were getting, people that were taking our review blitzes and, the practice exams and, being able to interface with us that way. Unfortunately, we do not have deep pockets to do, Google ads, which, I know a lot of these companies, they pay like, $20,000 a month to be listed, at the top of the search engines. We don't have that ability. So we rely on, word of mouth and, but we thought, well, maybe if we could do that word of mouth to help people who have purchased another course. We know the pandemic brought out a lot of people. Everyone thinks they can be an instructor, and some are very good, some not so much, but their prices are low and people fall for that. So either they're paying a lot because they're getting a big name and they're disappointed, or they're paying a little bit and they're getting what they paid for. So we've been doing this. I've been doing this myself since 1998. Alicia, you've been teaching about the same time?
No. Back in 98, I was more in the health system, working in the health system. I didn't start teaching until 2010, 2011 and stuff. So.
Yeah, well, not too far after. Yeah. But so that's why, if you've been let down, if you have purchased a full course elsewhere and you want to consider CCO, we're launching this program. We did this years ago and we're bringing it back. Oh, come on. I know why I gotta do this.
While she's looking at that, I can tell you, like Laureen mentioned a minute ago, it is probably the number one thing that is said when we have people that call and ask, because we do take your calls and kind of try to mentor you and walk you through. There's no sense in taking a medical terminology and anatomy class if you've already got that under your belt. And so, but that number one thing they say, like Laureen said, I wish I'd found you first. I wish I had money every time they said that.
I know, right?
But we always hear that.
Unfortunately, with this program, you can't get your money back from the other school. But we have like this transfer plan that we can help. So where we can maybe make it affordable enough to where you can take the course through us. The good news is you've probably already bought your manuals, you got your books. So we can probably offer some discounted pricing to get you into our program. And so all you need to do is reach out. I'm the one currently doing it. So you can go to this link, cco.us/Laureen-call, and you can book an appointment with me, a 30-minute appointment, and we can go over the plan. So that's for people who, have purchased other courses. You can also use that link as like a pre-sales kind of call if you haven't purchased anywhere and you just want to talk and get some questions answered. So I'm opening that up. It's going out on all of the social media. So I have evenings, and I opened up my Saturday mornings until I think 1 p.m. So there should be a slot for you. And if none of those times work, then send me an email, Laureen@cco.us, and we'll try and find another time. Okay. So if you could please spread the word. If you know of anybody who is struggling, let them know that we've got some special considerations, and we'll try and help them. Okay, so my turn. Let me bring my answer sheet up. Okay, good. So you can see that. So this is one prepared by Natalie. Thank you, Natalie. She's one of our great interns. I was supposed to present this last time, but somehow I got all mixed up and thought Alicia needed time, the whole time for hers.
And I did every minute of it, didn't I, Laureen? Every single minute.
Oh, that's all right. And you did. So it worked out. Okay, so the question was, can you provide examples of numbers and complexity of problems aspect to the E&M? So, E&M has morphed over the years. When I was first taking it, you had to know history, exam, and medical decision making. I would call it your HEM. So, but now the emphasis is all on the medical decision making. And in my opinion, that makes a whole lot of sense, because that's where it really shows the amount of thinking that the doctor had to put in to deciding how to diagnose the patient, what tests are needed, or how to manage the diagnoses. So, and it does make it simpler, but there's still a lot of nuances to master. And this is just one of them: number and complexity of problems. Medical decision making also has 3 pieces to it. It has the number and complexity of problems as the first piece, and then there's the data piece, and then the last one is the decision making. So this question is just about that one piece of medical decision making. So what patient scenarios justify the highest level of E&M? That's what this person, did we say who asked the question? I don't know where the question came from. So anyway, so it's all about the 99215, the highest level of E&M. What do we need as far as that first bucket with the number and complexity of problems? So this is the definition from CPT. You want to have 3 or more uncontrolled chronic illnesses, or a life-threatening acute flare-up, high-risk decisions, like they're going to go in the hospital or they need a surgery, like not a what am I thinking? It's like a surgery they need right away, not a, I want to say, is it voluntary? Is that what I'm thinking of?
Yeah. Elective, right.
And extensive data review and specialist coordination. So all of that would make a 99215 happy. So looking at history, we do still need, for any E&M, history, exam, and medical decision making. Even though this question is just about one portion of the medical decision making, we did include on the answer sheet history. It should be medically appropriate as needed for care. So it should match to the problem. So, if the problem's a sore throat, you're not going to have an elaborate history. But if they're having, recurrent headaches, and that could be something very minor, or it could be something very major, so they have to do a lot of different kind of workup. The exam should also be medically appropriate as needed for care. If no history exam is needed to support the medical decision making, minimal or no documentation of those sections is sufficient. That's the change since we went to medical decision making being the main driver. So for the medical decision making, we're looking for high complexity in order to warrant a 99215. So we need to see those multiple severe problems. We need to see an extensive data review and high risk. These are the three pieces of the medical decision making. So again, the questioner is really just asking more about this first bullet, but we're kind of going into a little bit more. So here's some real world examples that she found and came up with. So this would be a complex chronic case. So picture a patient that's 68 years old. That doesn't seem so old to me anymore. So this patient has uncontrolled diabetes. Their A1C is 10.2%. That's high. I think once you hit 6%, you're considered diabetic. So 10% is high. CHF exacerbation. Maybe they have this a new situation where their pitting edema is considered a 3+. That's pretty bad. They might have chronic kidney disease, stage 3. These are all chronic conditions, and they're multiple. So that helps, that supports that 99215 level for that first bullet of medical decision making. What are the actions that the physician took? He or she adjusted 4 medications. They ordered a renal ultrasound and a cardiology consult, and they spent 45 minutes counseling the patient on dietary restrictions. So how does that support a 99215? Well, we had multiple organ systems affected. There was a high risk of hospitalization coming up, and they had complex medication interactions that had to be considered. Okay, so that's the first case. Any comments on that, Alicia? I know we got some diagnostic stuff going on. We're switching roles tonight.
Yeah. This is I love this. And this is one of the areas that we see when we do audits, that a lot of the coders, it's like they don't have that confidence to go from a 4 to a 3. And I think part of that is their lack of knowledge of the disease process, knowing what is a diagnosis that is having problems, or a diagnosis that is high risk of morbidity or mortality. They understand mortality, but not morbidity. And so, like Laureen said too, if you have an A1C of 10, if you have an A1C with any other complications over a 7, you're probably going to get admitted. But that's just knowing the disease process, and you need to have that under your belt.
So let's do the next case. This is the acute crisis. We just had a chronic one. This is an acute one. So this patient has COPD, chronic obstructive pulmonary disease. They're on home O2, home oxygen, presenting with acute respiratory distress. And their SpO2 is 88%. I don't know what's considered bad for that.
Anything under 94 on room air is bad. Okay. So the fact that they are an 88 on oxygen, they're going to get intubated. Now,
as coders, we're not making those diagnostic determinations, but we're just educating you as we're reading this. What you're going to look at is acute respiratory distress. That's
and if you have a question, you query the doctor, and they're going to educate you. That's right. Your relationship between your physician and you. So that's right.
And this patient also has new AFib, atrial fib. And what are the doctor's actions? He ordered a stat ABG and chest x-ray, so some blood work and chest x-ray. He or she initiated NIV and IV steroids, so non-IV and IV steroids, and arranged for an ER transfer. So that's sounding like a level 5 to me for sure. So why? Because there's a life-threatening instability, and there's urgent high-risk interventions being taken.
Whenever they put you on an IV, they give you IV medications, that's almost just kind of a think to yourself, that's almost always going to be an level 5.
Almost always, but always check
just think in your head. That's your flag to say, okay, let's start looking at everything else. But
it's just like when we see a prescription med, we know they've got a 3 at least, right? So, okay, the third case is the diagnostic puzzle. So the patient has fatigue. They had a 15-pound weight loss. They have a new thyroid nodule, unexplained anemia, abnormal LFTs, that's your liver function tests. So what's the actions? The physician reviewed a 25-page outside records, They ordered a CT of the neck and abdomen and 8 lab tests, and they coordinated with 3 specialists. So although fatigue and some weight loss, I mean, a lot of us would be very happy with a 15-pound weight loss, but when it's unexplained and they're not doing any diet or they're not on any kind of medication that would cause it, that is cause for concern. So the 99215 is supported because of the extensive data review. I mean, 25 pages, that's a lot, and the multi-system workup. So hopefully you're starting to get a feel for, yeah, this is definitely a level 5. And you can see the different diagnoses: fatigue, weight loss, thyroid nodule, anemia. So those are 4 right there. The next example is the high-risk management patient. So this patient's been on chemo for metastatic cancer. They have a neutropenic fever over 101. They have severe neuropathy, and a depression screening came back positive. So what are the actions? The physician decided on hospital admission, adjusting their patient's chemo regimen, and a mental health referral. So that supports a 99215 because of the treatment complications and because of the multiple risk factors. And here are some common 99215 denial traps where the payers will deny you. If your documentation says stable hypertension or stable diabetes mellitus alone, then that's not going to warrant a level 5. Now, if there's an exacerbation, that's what the documentation needs to say. You might see things like where the markers have increased, or there's new microalbuminuria. So, I mean, obviously, if you see stable, that doesn't sound like it's real severe. If your documentation's vague, right, that's not going to support a level 5. But if you have severity terms, like the physician actually says, severe XYZ or uncontrolled diabetes or hypertension, or you see the phrase progressive, those are more supporting terms leaning toward a higher level E&M. Another mistake is missing risk documentation. So even though this particular question was dealing more with the diagnoses and complications, if it's high risk, like high risk for hospitalization or high risk because of the type of drugs that are being prescribed, then you want to see that in the documentation to support a level 5. And here are some AMA, American Medical Association guidelines. These are key changes since 2021 when we went to these MDM type way of doing E&M. If you're doing time-based, then for a 99215, you have to have greater than 40 minutes, 50% of which needs to be counseling and coordination of care. If you need to do even more time, then you can use prolonged services, which is an add-on code after you've reached the max time with your E&M code. If you're doing MDM only leveling, then the history and exam requirements, like we mentioned, aren't required per se, but they should be documented and they should be medically necessary. And then the medical decision-making elements that changed as of 2021 is you want to have those problems, the data, and the risk. Those 3 pieces together bring your E&M level up. Now, if you have problems and data that are very high, then that will still support a high level E&M. If you have problems and risk that are high, that will support a high level E&M. So basically 2 of those 3 need to be high. So, and that will support.
I mentioned just 2 things real quick about this when we're looking at the audits and stuff. Like you said, a number of problems and what those problems are, chronic, acute, et cetera. And that's what we focused on tonight. Laureen went over all of that first column, that the data, you've got independent historians and some other things, how much information you're going over and stuff. So it takes 2 of the 3, but I think the area that people struggle with the most is, and that's probably why this was asked, that first column, understanding the problems. And it goes back to understand the disease and the verbiage.
Yeah. I see a question in the chat. Michelle said, my plastic doctor wants to bill a level 5 when is consulting with a cancer patient, and they are consulting for the reconstruction portion being done at the time of the mastectomy, and he spends more than an hour with the patient. Some insurance are denying as not supported. What would he need to document to get a 99215 paid? So
Yeah.
the first thing that I want to say is, as a club member, you can paste a redacted case scenario in the club, and we will help you code it. We'd like you to tell us what you think it should be, right? The elements that you're seeing, and then we'll come in and let you know. And in this case, you could say, take a look at this report. We're feeling it's a level, 5, but we're getting denied. What's missing, right? And we can help you with that. So without seeing the case, cancer is a serious condition, but what else does the patient have? Why did it take an hour to talk to the patient? So maybe the documentation is just spoke to the patient an hour. Maybe it needs to be elaborated on. We needed to talk about this and that and the other thing, because it's going to affect their healing because they're diabetic, or like other pieces to bring into the story to bump that up.
And doing CDI work, I'd say too, a lot of that, most likely they're not documenting, but the questions that the patient has regarding what's my healing time going to be? What if the patient's spouse is involved and has questions? What procedure over, if I get reconstruction, how many CCs or da da da. There's multiple things. So the key terms, they don't have to list them all, is that the patient had complex questions that they answered, and state that the spouse had questions, and state, but we can tell you all of that. If you put this in the club, I got a plethora of CDI documentation tips that help with these type of questions.
Yeah. Very good. Good question. Okay. So CPT code grid, office visit. So this is just the basic, 99212 is a straightforward. They're spending about 10 to 19 minutes. I don't know why this looks a little wonky here. Oops, wrong one. That looks a little better. Okay. 99213 would be your low. That's 20 to 29 minutes. Typical diagnoses, mild asthma, UTI. Oh, so for the 212, stable acne, medication refill, you can see how that would definitely not be a high level one. Then moving up to a 214, that's your moderate. That's 30 to 39 minutes. Uncontrolled hypertension, new depression. So now we're seeing like level 4 type examples. And then your 215 is a high, greater than 40 minutes. And you're seeing multiple chronic and acute severe cases. So MDM elements for 99215, high complexity, number and complexity of problems, must meet one. This comes off your typical E&M little worksheet where you're checking off things to get credit, to get the points, to figure out what it maps to. So for the number and complexity of problems, which is what our discussion or questioner was asking about, you need to have one or more chronic illnesses with severe exacerbation. Exacerbation is like a flare-up. It's gotten worse. They might have chronic I don't know. Give me a.
Well, they could have, say something as simple as chronic back pain. Okay. But now they have numbness and tingling in their feet. They didn't ever have that before. So that it could indicate that the nerves are being compressed and they may need to have spinal surgery. So that, because you think back pain, how can that, but that's an exacerbation of a chronic illness.
Yeah. And this example is COPD, but now they have respiratory failure. So they have chronic obstructive pulmonary disease. They've had it for years, but now they have this flare up. They have this respiratory failure on top of it. Acute life-threatening condition. So chest pain, and they're going into the ER. So that's, acute. or they have multiple complex conditions. So they have cancer plus chemo complications. So back to the question that Michelle asked, is it, I mean, I don't want to say just cancer. I mean, that's bad enough, but do they have other chronic things going on? Chronic hypertension, chronic diabetes, so systemic kind of diseases that affect the healing of the body and will affect the way that a reconstruction plastic surgeon is going to go about doing what they need to do.
And the multiple chronic conditions could be those basics. They have hypertension, the HLD, and they have migraines, they have morbid obesity, they have, and then you list off, and then they start saying that they're having other, they're trying to determine what it is that they're in there for. Is it one of those like 5 chronic conditions that they have? So that number of chronic conditions makes a big deal.
Yep. And then the other 2 medical decision-making elements, piece number 2 is the data, piece number 3 is the risk. So for data, 3 or more tests or images were reviewed or ordered. Independent historian or a specialist consult. So maybe they had to go to a family member to get the information because the patient is mentally not with it or incapacitated. Maybe they had a stroke and they can't speak. So
a parent and a child.
Yeah.
An independent, and the independent historian doesn't have to be there in the room. I had one where, she had, they're trying to determine if she had epilepsy, and she couldn't tell her what the convulsions were like. So she called her husband, and the doctor talked to the husband about what he heard and saw the patient do. That's an independent historian.
Yep. And then risk, it has to be high for 99215. So drug therapy, IV, like Alicia mentioned, is typically going to bump it up to a higher level. Opioids, chemo, immunosuppressants, the kind of decisions that the physician makes indicates risk. So if the physician's like, they need surgery, okay, that's high risk. If the physician's like, okay, you're going to the hospital like now or tomorrow morning, then that's high risk. The diagnoses, if it's a progressive or terminal illness, that is going to bump up the risk. So these 3 together, again, you can have 2 out of the 3 will raise it up to that level 5.
But tonight the main focus was that very first one.
Yes.
We could go in and spend another whole hour on each of the other 2 areas.
Yes. So here's some pro tip using the AMA's medical decision-making table. You can go find this, just Google for this AMA E&M table, and you'll see these are like the little checklists. It's a little blurry here, but it's showing you the code levels. It's showing you, the name, straightforward, low, moderate, high. This is the number of complexity column. This is the data column, and this is the risk column. So you can see if you're using this as a, let me see, how did Alicia do that? If you're seeing a high, I don't know if this is going to work on the image, maybe not.
I think it won't work on the image. While she's doing that, though, I was going to say, this is what I have at my desk. I have Don Self's little miniature grid that can open it. It's thing. I don't know how much, I can't remember how much he charges for, but it just can fit in my computer bag if I have to go somewhere, or it sits on my desk. And but these grids are everywhere. You can get them.
So if this is low, moderate, high, and let's say we have a high amount of diagnoses, right? It scores a high, but the data is limited, but the risk is high. Maybe they gave them, IV, whatever. So we have a high, limited, high. What do we score it? Do we score it a moderate? Does the limited pull it down to a low, or can we code it a high? What do you say in the chat?
And remember, you have to meet or exceed. And example, let me give you an example. A patient comes in with a rash. They were recently given an antibiotic for a UTI, and their throat is scratchy and dry. They don't feel good. And the doctor doesn't review any data, but he sends them to the ER because they need or he gives them an epi injection and sends them to the ER. So one diagnosis, well, technically two, UTI. You know, yeah, that's a high.
Yep. So Michelle got it first. She called it a high. And Cynthia, you're right. 2 out of 3 equals a high. So we got 2 of the columns that were at that high level. So we can take it, which is nice. So, and let's see, we got Denise got it right. And Kathleen. Good job, guys. Good job. All right. Let's get. So FAQ, can I use 1997 guidelines? Yes, but probably want to use the 2021. It's easier to get higher levels. Does Medicare follow these rules? Yes, since 2023, but always check your specific bulletins for the Medicare carrier.
I would, just one thing I just thought of in the middle of what Laureen was saying, don't forget, we get to choose what's most beneficial for the clinician. Medical decision making or time. So if they said, I just audited one where they did the auto text that they spent 17 minutes, with the patient before and after, blah, 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 blah. But the medical decision making was high. And it was like, this could have been a 5. It doesn't matter that they spent 17 minutes. They hit all 3 of the sections. So don't fall in the trap of going with time. Remember, you get to pick or choose which is the most beneficial.
Yep. All right. So that wraps that one up.
We are at 8 o'clock. Do we want to table mine till next time? Or
I'm thinking so. Yeah. Okay. And maybe that'll be our new pattern since we've become very verbose in our old age.
Yeah. We just talk too much.
Oh, it's all right. So this is just a reminder slide that the CCO Academy, I had someone today asked to get on the early bird list. I said, oh, it's launched. July 4th, we launched it. So just go over to cco.academy and you can join right there. Everything, all their coursework is moved over. There's a few other things that we're trying to move over there. We're moving the help desk over there. So it's all contained in one app. It's mobile. You can put it on your phone. You can put it on your tablet. So please go check it out. It looks really modern and pretty. I just love it.
The mobile friendly thing, I think, is one of the biggest kudos. Mm-hmm. Not everybody can pull that off, and we've done a good job.
That is another complaint we heard from that larger school, was that while they do have online, it's very buggy and doesn't work well. And it's like people just abandon it. They just give up on it. So this is very slick. And the team worked really hard. We got everything moved over relatively quickly. So come show them your appreciation by coming over there. Post, introduce yourself. We've got a free area, so you don't have to be a club member, although we, give you lots of benefits when you're a club member. And of course, when you're a student, we consider our club members and our students our premium members because they help support us and keep the show running. So thank you to our premium members. We also have kind of rebranded. We're going with the CCO Academy as our new kind of brand. So our YouTube channel has been refreshed to bring that out. And I'm proud to say that my 20-year-old is running my YouTube channel right now. So his name's Michael. So give him a shout out. And I think he's doing a good job. And Mary helps a lot with graphics as well. So we really appreciate them. And of course, Sylvia is helping with the slide decks and helping with the interns because she is a certified coder herself. So I remember when she was watching my Blitz videos and her young daughter at the time would say hello to me because she always had my videos on. And now her daughter's all grown and doing well. So, all right, so we're going to save this one for next time. So just to whet your appetite, we're going to talk about the endovascular cases on spine angiography and obviously, something else. Our intern program is open. So if you are interested in doing some of the work that you've seen on these answer sheets, come check us out. just go to the cco.us website. You'll see where we have for the interns to do that program. Then these are the webinars that we have. We're doing 3 a month. We have the Academy podcast. That's the one that we did last time. We're going to get better at making those topics more where you only have to listen. So if you're at work or on the treadmill or whatever, and you just want to listen to kind of like general coding news, we want to do interviews. So if you are interested in being interviewed, it can just be about how you became a coder, what got you interested in coding, how did you do it? Did you do your if you took the AAPC exam, did you do it at home or did you do it at the testing site? So please reach out to us. If you don't want to show your face on camera, you don't have to because it's a podcast. But we will be doing it like this where it will show up on YouTube, but you can just be a little, picture or whatever. I do have someone who's going to come on who is really good at using the AI in the new app. That's another benefit. The AI is being trained on all of our content, every single course, and it's awesome. I can't even believe the answers it comes up with. I'm like, that's in our courses? And it's like, yeah, and it gives you the reference, what module it's in. And even if you pay for, like, say, the PBC course, it's looking at all the courses. So it might find the answer from the risk adjustment course and pull it in. Now, you might not be able to go click on the details of it, but you still get the answer from the bot. So really, really cool. So tonight we're doing the community Q&A one. So give us your topic request. Let us know what you want us to answer. Give us an op report. We'll code it together. And then we do the club webinar, which those are more where it's kind of one topic long, and will typically be Alicia presenting that. So these are the 3 webinars we're doing. We also have, check out our calendar. Just go to, oops. CCO.academy and go to where it says events. And we've got this nice calendar format now, so you can see what's coming up. So what's today? Today is, I cannot believe it's the 14th already. So next Thursday, we take a breather, and then the 28th will be the club. And we just keep repeating this format. When is our... Is this the... Click on learn more. I thought we were doing ICD-10. At any rate,
How active it is too, though, because see how she did that? She clicked on that, and then you can have a conversation about an upcoming webinar. Mm-hmm. So I think it's real intuitive that way too. I think it's great.
Yeah, and register here via StreamYard, because when you're in StreamYard, we can pull your comments in. We can, see who's answering better. So it's always good to do that. Register. Although you can watch it live on YouTube or wherever, but it's much better if you're like in the container with us, so to speak. But we are having the 2026 ICD update. I thought it was in August, maybe it's first thing in September, but just come here and get signed up for this and you will be notified. So what else did I want to tell you? So topic request, you just go to cco.us topic-request and you can fill out that form, and we'll get that question worked up, and the interns are turning these over really quick now. So you could ask a question today. We could be covering it on next week's webinar, probably 2 weeks, but that's how fast they're doing it. So feed our interns. They want stuff to work on. Okay, well, that's it, guys. We're going to let you go. Thank you so much for your time. And, we look forward to work with you. Please spread the word. We need that word of mouth. We really appreciate you all. Any last words, Alicia?
Well, I just think that it's important for us to build that community with each other. Many of you guys know we've been around for a long time, and that's what we're trying to continue to do. We've had a community for a while, but now we're just moving into that new updated and upgraded format for us to be connected. And so I look forward to seeing you guys on the app.
I'm going to throw in one little kudos. Barbara took the time to write it. So she said, I started working on the Blitz the way you suggested and found it makes way more sense to me. Thank you. I've waited 9 months if I needed to get into that. So basically we were talking about on I think a coaching call with the BAT system, bubble, highlight, annotate technique. When to do it? Do you do it all at once? I prefer, in the way I've always taught it when I was teaching face-to-face, is like, say we were going to do the digestive system. I would have the students bubble and highlight, and, you know, basically that's what they would do. They'd do the bubbling and highlighting prior to the class. Then when I was teaching, because I was teaching from the manual, I would tell them what notes to put in the bubble. So I tell people to still do it that way. You know, Darcy, she kind of likes, she tells people to do it at the end. So, you know, it's like, you can do it however you want. It's just different preferences, but it really helps when you start marking up that manual. And the other student I was talking to last week was like, it's just like, you're right. You become one with your manual when you mark it up that way. And by the way, we are going to be, let me see how much I want to reveal. In the Bat Cave, we have traditionally done videos. We're going to be offering not PDFs that you can print, but it's going to be more of a, you can view it, copy it into your book, move it along, copy the notes into your book instead of a video that you have to stop and pause. So that is going to be a part of the Bat Cave for the annual club members. So look forward to that when we do our 2026 manual updates. So, okay, everyone, you have a good evening. Thank you, Alicia.
Bye, guys. It's always good to see you, and tell your friends and peers.
Yes, thank you.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.